So these are my disclosures. I will do an overview on the evolving spectrum of multisystem proteinopathy. I will start with a historical background, talk about VCP protein structure and function, highlight the most common phenotypes, and then spend a few words on treatment. The VCP story began exactly 20 years ago when Dr. Kemonis and her group identified the VCP as a causative gene of inclusion body myopathy associated with Paget disease of the bone and frontotemporal dementia after mapping the gene to chromosome 9. The first association between myopathy and Paget disease, however, dates back in the late 50s, when Paget disease was reported in patients with dystrophia myotonica, and a decade later in patients with Paget disease and myotonic dystrophy. The first VCP mutations were detected in 13 families with this disorder, whom affected family members manifested with inclusion body myopathy and Paget disease of bone in the early 40s, while frontotemporal dementia followed about a decade later. This patient shared a common pathological feature of muscle biopsy, which was the presence of small and large aggregates containing VCP. Of interest, all mutations affected only 4 amino acids, which were mainly located in the linker domain of the protein, suggesting a possible hotspot. Now, since then, many more mutations have been detected, all scattered along the whole gene, but still more concentrated in the linker part of the protein. Now, VCP, as you know, is an ATPase, and it has 4 domains. An N domain, which is essentially for the for binding substrate, and then a D1 domain that has a crucial role for oligomerization because VCP operates as a homohexamer in mammalian cell. Then there is the D2 domain, where resides most of the ATPase activity, and the C-terminal, which is important for the nuclear localization. There are then the 2 linkers, which are equally important for VCP structure. For example, the linker between the D1 and the D2 domain is important for the D2 domain ATPase activity. Now, VCP is a protein that evolutionarily is very conserved. It is expressed in many tissues. Is present in skeletal and cardiac muscle, is present in the central nervous system across a variety of cells, kidney, liver, ovary, testes, and lung, and at the subcellular level is present in the cytoplasm, Golgi apparatus, nuclear envelope, endoplasmic reticulum, and mitochondria. It's a protein that has a broad spectrum of cellular function. And essentially, it is a chaperone-like protein involved in protein control system, protein quality control system, being a part of the ubiquitin proteasome system and autophagy. Interferes with DNA replication, is crucial for calcium homeostasis, participates in the maintenance of the endoplasmic reticulum, Golgi apparatus, and even mitochondrial function. Now, in regard to autophagy, there is this very nice cartoon that is included in Ferrari's paper representing the pathway of autophagy and highlighting at the different steps at which VCP intervenes. VCP participates in the activation of the transcription factors, is important for routing misfolded protein and organelles to autophagy, promote the initiation of autophagy, and participate in the maturation of the autophagosome. So considering that VCP is a protein so ubiquitous with a broad range of cellular function, it is not surprising to realize that and to see that mutation in VCP may lead to such pleiotropic disorder. A few years ago, the term multisystem proteinopathy was adopted to indicate the coexistence of inclusion body myopathy, neurodegeneration in the form of ALS or frontotemporal dementia, a Paget disease of a bone, segregating in the same, present in the same individual, or perhaps segregating in the same family, with a pathological hallmark represented by the presence of ubiquitin positive, a TDP43 positive aggregates. Now, it turned out that this phenotype has genetic heterogeneity, and there are other genes that can lead to multisystem proteinopathy. So VCP, multisystem proteinopathy, became a multisystem proteinopathy 1. So the phenotype is mainly dominated by the myopathy. It's the most common clinical manifestation, manifesting in about 90% of the patient with a mean age of onset in the mid-40s, although now we know that there are patients with a much earlier onset. And they can have a variable distribution of the weakness, as we will see. Paget disease of the bone affects up to 50% of the individual, while frontotemporal dementia may manifest in about 15-30% of the subject. Motor neuron disease is a rare manifestation. Now, there is no clear genotype-phenotype correlation, but we also have to remember that about 70% of patients with VCP multisystem proteinopathy have a mutation that affects the amino acid position 155. These mutations, however, are very highly penetrant, and as we said, about 90% of patients will become symptomatic by mid-40s. More specific mutations have been associated with Charcot-Marie-Tooth or isolated dementia. Now, when we look at our patients with VCP multisystem proteinopathy, most of them, in agreement with the published data, had inclusion body myopathy. About a third of them had the Paget disease of the bone, and 2 had a coexisting axonal length-dependent peripheral neuropathy. Motor neuron disease was present only in a small proportion of patients, and 2 of them had the pathological evidence of a coexisting inclusion body myopathy. Frontotemporal dementia was present only in few subjects, and only 1 case was the symptom of presentation. However, in the course of a neurological evaluation, that specific patient was found to have also a myopathy. Looking at the pattern of the weakness distribution, most patients have a limb girdle weakness, and fewer had distal weakness. A few other patients had a scapulodistal weakness. These are photographs of 2 patients with VCP multisystem proteinopathy, a different phenotype, one manifesting with proximal severe limb girdle weakness, a scapular winging, and the other one with very distal weakness, which had initially misled to the presumptive diagnosis of Charcot-Marie-Tooth. When we compare the clinical findings of patients with VCP multisystem proteinopathy with other multisystem proteinopathy or multisystem proteinopathy-like disorders, the most striking difference was between VCP and sequestosome 1 and TIA1, which also can cause multisystem proteinopathy. The patient with the latter disorder had a predominant distal or scapulodistal weakness, and none of them had the Paget disease of the bone. An interesting data is pertinent to the mass pathological findings. The large majority of our patients had a rimmed vacuole on muscle biopsy. This data is a little bit in discrepancy with the published result that report 40% of patients have vacuoles on muscle biopsy. The other difference was that we noticed rimmed vacuoles in non-atrophic fibers, while a few years ago it was underlined that vacuoles may be more frequent in atrophic fibers. Such difference in finding could be explained by the anatomical site of the biopsy. Sometimes a biopsy can be performed in a minimally affected muscle because it's easily targeted by the biopsy. In our cohort, the patient with distal weakness or scapulodistal weakness had a biopsy of a distal muscle. The other element to consider is the fact that the distribution of the rim vacuole in muscle tissue is not homogeneous. And indeed, when we looked for a number of rim vacuole per lower power field, there was a range varying from 0 to 7. So considering the variable distribution of the vacuoles in the tissue, and considering also the muscle biopsy size, open biopsy versus needle biopsy, you can perhaps try to give an explanation about this variability in findings. Now, I like to share with you this patient because his pathological findings are a representation of what I just said. So this is the patient who has, as far as I know, the earliest onset of the myopathy at age 16. And although he was seen in his 30s, age of onset of the weakness was very clear because it coincided with the discontinuation of growth hormone replacement for growth hormone deficiency. So there was no doubt about the date of onset of the weakness. And he had been referred for a non-5q spinal muscular atrophy based on a neurogenic EMG study. He became severely weak, and essentially by age 35, he was wheelchair bound. He was known to have elevated alkaline phosphatase since his early 30s. His radiological studies show the finding consistent with Paget disease. As you can see here, there was trabecular changes and the cortical thickening of the ilium and the proximal femur, as indicated by the arrows. The radiograph of the skull show also features of Paget, especially in the calvarium and the parietal bone. And the MRI of the cervical spine showed deformity of the C3 vertebral body, which is the arrowhead, with expansion of the posterior element, also a feature of Paget disease. And there was a marked atrophy of the paraspinal muscles at the cervical as well as lumbar region. This patient was found to have a novel variant, and in silico model gave conflicting result from deleterious to benign. But a different mutation at the same codon had been reported in a family with multisystem proteinopathy, and I isolated the patient with multisystem proteinopathy. So there was a high likelihood that the variant was pathogenic. And using a two-dimensional model of VCP bound to ADP, it turned out that the mutated amino acid is very close to the ADP binding site. Previous study had already shown that the variant at position 155, the most common mutation detected in VCP, can alter the structure and the ability of binding ADP. So it's very changing the structure of the protein. So it is very likely that the novel mutation in this patient could have a similar effect. But coming back to the original observation on the muscle biopsy, this patient had two muscle biopsies, one of the extensor carpi radialis and one of the deltoid. While the biopsy of the extensor carpi radialis showed florid myopathy with rimmed vacuoles, and the staining for acid phosphatase show overreactivity in the vacuole, the red dot, as well as in the sarcoplasma suggestive of lysosomal overreactivity. The biopsy of the deltoid did not show any vacuole, did not show TDP43 or P62 positive aggregates. There were some region of the deltoid biopsy where there was just a mild increase in internalized nuclei, rare fiber splitting, a mild increase in endomysium, so very mild, no specific changes, alternated with area where muscle tissue was replaced by fatty connective tissue. Sorry, the arrow doesn't work too well, so I have trouble using it over here. The other feature that the biopsy show reinnervation as seen by the extensive grouping of the type 1 fibers, the brown fiber. And this brings up a question: if anterior horn cell disease involvement is underestimated as a contributing etiology to the weakness or to disease progression when we make the diagnosis of inclusion body myopathy in this patient. Or there is also some bias from the neurologist who see these patients. If we look at this paper, a group of patients, 71 subjects with non-5q spinal muscular atrophy, this was the presumptive diagnosis of the patient. A third of this group of patients had a molecular diagnosis, and 2 of them were found to have a VCP mutation, one with a proximal phenotype and one with a scapuloperoneal phenotype. But none of these patients had a muscle biopsy, so can we really conclude that this is a spinal muscular atrophy, or there is the possibility that this patient may also have a myopathy contributing to their phenotype? Now, interesting data have been published by Dr. Diaz-Maner and his group on MRI finding of VCP as a feature to further characterize this disease. They found that at least there was fatty atrophy in at least a muscle in symptomatic subject, and they described this focal pocket of atrophy, like seen in this picture below, marked as E, with fatty atrophy, focal fatty atrophy of the trapezius, while the periscapular muscles are spared. The other data that were interesting about the MRI finding was the enhancement of the subcutaneous tissue in the STAIR images and at the periphery of the vastus lateralis, which did not match any change in signal in muscle in the T1 weighted images. There are also some more rare manifestations of VCP mutation, which include cardiomyopathy in the form of hypertrophic or dilated cardiomyopathy, right bundle branch, left bundle branch block or atrial fibrillation, but no patient has been reported with pacemaker or defibrillator. Cardiomyopathy seems to be rare, although it was reported in several subjects in an Asian cohort. Tumors of rare types have also been reported in this patient. And among the least common neurodegenerative manifestations, there are hereditary spastic paraplegia and Charcot-Marie-Tooth. Now, a lot of emphasis has been placed lately between VCP and Parkinsonism. If we look at the 2 largest cohorts, Parkinsonism was described only in about 3 to 4% of the patients. Already this year, there are 2 reports of patients with Parkinsonism manifesting in the setting of associated myopathy and with or without Paget disease. But there is also a report of a patient who has isolated the Parkinson disease, no family history, and carries a mutation that was previously reported in the setting of familial sporadic ALS. Now, Parkinsonism can manifest. Parkinsonism associated to VCP has been reported as classic Parkinson disease, so asymmetric Parkinsonian features responsive to carbidopa-levodopa with decreased uptake in the putamen, as you can see in the over here, which are a classic feature of Parkinson's disease. But there are also patients who present with more broad Parkinsonism, like this subject who had the clinical features of progressive supranuclear palsy, mainly characterized by postural instability and vertical eye movement abnormalities. But contrary to true progressive supranuclear palsy, this patient did not have the pontine atrophy, which is a feature of PSP. Now, when we think about PSP, such disease is categorized as tauopathy. And it is of interest that this article recently published by Zempel links VCP to tauopathy. Some of the true tauopathy are related to a mutation in this gene called MAPT. So I'm sure you're familiar with. They encode for all the isoform of tau, 6 of which are expressed in the CNS, which leads to accumulation of tau in brain cells. but VCP is also mechanistically linked to tauopathy. Now, this information comes from the recent paper that describes a form of frontotemporal dementia defined vacuolar tauopathy. So these two families had isolated dementia with clinical features of frontotemporal dementia associated with this particular VCP variant, a position 395. But the pathological findings were quite peculiar. So moving from the frontal cortex to the visual cortex, the degenerative changes and the tau accumulation were decreasing, and the vacuolar changes were increasing. Now, interestingly, while most of the VCP mutations associated with multisystem proteinopathy result in increased ATPase activity, this one causes loss of ATPase activity. So the thought is that because VCP can unfold the protein substrate, if it is mutated, favors the accumulation of the tau that tends to accumulate. So essentially, if we see patient with VCP, a clinical picture of frontotemporal dementia, we may be in front of two different scenarios. One with increased ATPase activity, a gain of function mutation leading to a TDP43 pathology, and others with loss of function with decreased activity, decreased ATPase activity, tau aggregates, and leading to vacuolar pathology. But in reality, this is a pathological diagnosis, and clinically is impossible to differentiate between these forms. Now, along the same line, Dr. Weil and the collaborator identified the VCP mutation in a patient with developmental delay with childhood onset. This individual presented intellectual disability, hypotonia, and microcephaly. The mutations were distributed along the gene, and with the exception of one, and VCP activity was decreased. So it was specified that there was no clear overlap in symptomatology with the multisystem proteinopathy. There was no evidence for myopathy, but only one subject had a muscle biopsy. There was no evidence for bone disease. However, 3 subjects had peripheral neuropathy by electrodiagnostic test. So at this point, should we still keep talking about VCP multisystem proteinopathy, or should we perhaps reconsider and talk about VCP-related disorder? Now, the diagnosis essentially requires a genetic confirmation, but because there are multiple multisystem proteinopathy, they can have a phenotype quite similar. One problem that comes up is how to deal with variant of unknown significance and family counseling. I'm not going to discuss family counseling here, but I would like to touch on the variant of unknown significance. Dr. Diaz-Manera published this interesting article with proposing a scoring system where phenotype, family history, muscle biopsy, and MRI would be considered in addition with in silico analysis and ATPase activity. However, sometimes if a patient does not have a myopathy, we may be in trouble in interpreting the VUS. Now, a lot of progress has been done thanks to this organization for the management of patients with VCP mutations. And there are recommendations, although these are based on physician experience. These patients require very close follow-up. They need to be monitored for their respiratory status, for their cardiac status. A recent paper also underlined how training can occur at distance, improving respiratory function. Now, regarding treatment, there is no cure at the present time. There are no approved disease-modifying agents, but there is a lot of research in this area. And I'm showing this table just to share a summary that has been recently published, but is just, the hope is just in all of you scientists who could advance knowledge in this field. There are also, just to be optimistic, although the paper has not been already published, there are 4 novel compounds identified that are able to alter the phenotype. And we can learn more also from drugs that may be approved for other fields. Additional potential therapeutic approach obviously would include the antisense oligonucleotide, RNA interference compound, gene delivery, but we're still in the preliminary phase. So we need to better understand essentially the spectrum of this disorder. We need some biomarkers, and we need some model that could better represent the disease to allow us to intervene and to use more efficacious therapy. I would like to acknowledge my colleagues and our funding, and special thanks to Cure VCP Disease and its main representative, and thank you very much to all of you.
We have 5 minutes to take questions, and the microphones are going to just raise your hands, and we are going to bring you microphones.
So, given the complexity of VCP function and many cofactors that work with it, I wonder whether, I was just thinking about that last slide where you were relating the different mutants to ATPase activity. And I'm just wondering if that's an overly simplistic way to think about the mutations, given the potential, the ability to assess the function of the enzyme is going to very much depend on its biochemical context, I would think, given all the cofactors and especially the different places it plays a role. And so as we think about therapies and ways to modulate function, I think it might be challenging if we apply only a unidimensional way of classifying the mutants. And I'm wondering what your thoughts are about other approaches to classify the mutations, perhaps in other more sophisticated biological or biochemical contexts.
Yeah, I agree with your observation. I mean, there is no doubt about this. But this is what is known so far. So if you can come up with a better classification of the variant, also based on the functioning, I think it would be ideal. But based on what we have, I mean, I would trust the scientists, people who work in basic science. I mean, all of you who work in basic science who can bring to the table some more.
Patients with mainly loss of function, and you've shown us that there's gain of function and loss of function in classic VCP. Can you help us put our heads around what we're seeing as such a variable phenotype?
Well, if I knew the answer, I think we had solved many of the problems. I think that probably the protein is so polyedric and it has so many functions. Probably we know just a fraction of the function and we know a fraction of the interaction. Because also I mean, Chris can comment on that, his patient, is the mutation detected in his patient, one of them had increased, I mean, not all performed the same way, right? So I'm sure there are many more factors in the scheme that we don't know well. I think we just know the tip of the iceberg of this disorder. And the fact that one protein has increased activity, one mutant has increased activity or decreased activity may be just a part of the spectrum, but may interact with other components.
I can speak up. So just limiting to the neurological manifestations of disease. So you mentioned you may have ALS, you may have Parkinsonism, FTD, or Alzheimer. Can you stratify according to the clinical phenotype, the pathological phenotype based on histology, postmortem, and you can only do that in brain postmortem, and with respect to the mutation, is there a stratification possible? For example, saying less VCP activity versus more? Or is there any way to stratify?
I'm not so sure about this, but because most of the mutation, the large part of the mutation are concentrated in the N-terminal of the protein. So I'm not so sure, statistically speaking, how meaningful that would be.
And if you have a pedigree, a family, is there a kind of succession with a specific clinical presentation of disease, or do you see this variance, this heterogeneity also in the pedigree of one family?
Yes, there is variability within the same family, not only in terms of phenotype, but also age of onset. At least this has been my experience.
Thank you.
Yes?
Has anyone done an experiment where they've taken mice with specific mutation and looked to see the effects of background? So the question I'm asking is, even in a family, of course, siblings only share 50% of the genetic material identically. So the question is, to what extent do you think, or is there the impression that genetic factors are impacting the heterogeneous presentation versus sporadic events in the genesis of the disease?
Well, that's a tough question. It's probably a combination of both, but that would be just my guess.
So nobody's done a mouse cross, nobody's taken the mice and stuff, there were a whole lot of backgrounds.
Frankly, I cannot answer this question because I don't know all the mouse animal models that have been studied in terms of VCP. I'm sure somebody in the audience may know that. They can comment, they can answer your question. Chris, do you know?
We've never done that. I don't know if Virginia has, but I guess I want to make sure I understand David's question. So you're asking whether it would manifest with a different phenotype?
Yeah.
So I think the first thing we need is to have a mouse that really shows a robust phenotype in general. But
you don't necessarily need it, so you could take a chance. So if your mice don't show very robust phenotype
right.
on a black 6 background, you can cross them to a number of different backgrounds and say, does this reveal a phenotype or different phenotypes? I think that's,
absolutely.
This is a huge challenge.
It's
a huge challenge in other neurological diseases as well.
Right.
But I think that if there were a way to deconvolute this complexity, it would help a lot in terms of thinking, what the consequences of mutations are, at least. I mean, it's a few steps downstream of what Mark's talking about, which Mark will know that. I think you need to understand the cell biology and biochemistry really carefully. But I think, at the organismal level, I think this differential phenotype with the same mutation is a very interesting challenge.
So you bring up a very important point. So the first mouse I made, which was a knock-in, and we're still working with it, and unfortunately it lost its phenotype. But the very first mouse was made with a different background, an SV6, and it had an amazing phenotype. It had vacuoles, it had seizures as well, and weakness. But then we were told, no, you need to put everything on a black 6 background, which is what we have worked on since. And we keep backcrossing and backcrossing to get it. But, you know, it lost its phenotype over the years. And then Chris made a mouse that also Paul Taylor's mouse, which is the A232 overexpressed mouse model on a human. It's a humanized VCP. The publication showed that it had a beautiful phenotype. I don't know, Chris, if you worked with that mice, but it is no longer the same mouse as what was published. And unfortunately, the overexpressed R155H got lost, you know, in translation when they derived it. So there is a huge need for a better mouse model, and maybe what you're suggesting that are existing, which I think the cleanest mouse model is the one with the knock-in mutation, to put that on different backgrounds and see if we can get that phenotype again. Yeah.
I would like to comment on this phenomenon. The heterogeneity of disease and the difference in the mouse models may point to modifiers and the genetic background providing modifiers. And the opportunity may be, and this has been shown, for example, for other monogenic diseases that are hereditary, like, for example, Crumb's mutation, that these modifiers may not be only destructive, but they may be protective. And the look for protective modifiers that's currently going on, for example, for age-related macular degeneration, where we know that there are positive modifiers that protect from this form of age-related retinal degeneration. These modifiers could lead us away to treatment strategies if they are protective.
Right. That's a good point.
Last question. So I was just thank you very much.
Thank you. That's so kind of you. Thank you.
I will invite you all to continue the conversation. We still have 2.5 days together, but now it's poster session and reception. So I will invite you to move out on this.